Hey, how you doing? My name is Adam Klingsheim, and I want to welcome you to today's presentation. Today we have with us Laurie Jaccard, who serves as the president of Clinical Intelligence, a healthcare consulting firm which she founded in 2001. CI specializes in designing and executing best strategies for clinical, operational, and margin performance improvement at hospitals and health systems, especially around the area of reducing unwarranted clinical variation. Laurie and team have facilitated over 150 clinical performance assessments and redesign engagements in 44 states, ultimately transforming and optimizing clinical performance for hospitals by applied analytics, care coordination, and clinical integration. Laurie is a visionary, passionate about improving the healthcare system in the United States and building solutions and teams that inspire change. I want to go ahead and introduce you to Laurie. We have a few questions for her. Hey, Laurie, are you there?
Yes, Adam. Good afternoon.
How you doing?
Doing great.
Okay, Laurie. Well, we know that CI has been helping to establish clinical variation reduction programs at hospitals throughout the country. This is such an exciting and relevant topic. As we begin our conversation, it might be helpful to start by sharing the definition of clinical variation, along with the first steps a hospital can take in beginning a clinical variation journey.
Thanks, Adam. Glad you asked the definition because there's so many definitions of clinical variation and because it can mean there's so many aspects of clinical variation. So you break down the word clinical and you look at patient care quality. You break down the word clinical and you look at efficiencies. Are we moving patients through the system? Are we utilizing the right resources? Are we getting the patients in the right level of care for their condition? Are we overutilizing hospitalization days? Should we be moving patients to the next level of care, such as a home health, a post-acute partner, or a skilled nursing facility, or back to home with support? So think of clinical variation as the variability, or if you were going to look at the dispersion around the mean, that's the variability we're looking at. So it could be healthcare resources that create suboptimal value. And so how do you reduce clinical variation? So how do we reduce clinical variation in a healthcare organization such as a hospital? It starts with understanding your data. So uncovering that opportunity, you have to define how much variation, how much variability do you have in your organization? And you do that by pulling the patient level data and the charge level data from the existing electronic health records, just flat data files. And clinical intelligence takes those files and we organize the data. So the data is very actionable. It's insightful. We can quantify how much variation there will be in any organization by looking at that dispersion around the mean and quantifying that variation coefficient, looking at the variation curves. So now that we've defined clinical variation in the field, what is clinical variation? How is it identified? Again, it's identified by organizing the data that exists in every hospital in a way that we can analyze the data and identify where that variation exists. So I'll give you an example. The number one diagnosis in our country for hospitalization is sepsis, septicemia. It's a condition that is a result of infection and the impact on various organs. And so sepsis, there's a lot of variation naturally because of the severity of that illness. And also there's variation because the patients who have sepsis might be older, they might be younger. So there's variation in their comorbidities or existing conditions. So a patient with sepsis that has heart failure and a patient that has sepsis and is a 20-year-old that got a bug bite, they may have variation just because of the nature of their severity of their illness or their intensity. So what we have to do is there's no perfect way to normalize all the variation out, but we really use that data to identify the variability. So variation exists in every population, and you can't remove every bit of variability out of the system. But the benefits of reducing variation is improving quality. So you cannot improve quality without first taking that variability out of the equation. So what we see is when we take that variability out, so imagine the sepsis patient that I just described coming in, and if all the physicians, let's say there are 50 physicians treating septicemia a different way, you're going to expect to receive different outcomes. Maybe they're using different antibiotics, or maybe they're not administering those antibiotics timely, or doing the right laboratory tests, or the right cultures. So what we try to do is we try to create standard work around clinical care. We create that work with physicians and team members who develop what we call protocols or evidence-based guidelines. And those essentially are the order sets that the physician writes to actually administer the directions and the directives for that care team. So if we can create protocols for patients based on evidence in the literature, scientific evidence, level 1A evidence, we can bring that evidence into the hospitals, take better care of patients, improve the quality, and what will happen there is most likely the cost will follow. So the cost of care, typically very unusual, but as you improve quality of care, your cost actually drop in most cases. Now, sometimes when we improve quality, we have to spend more, it costs more, but in most cases, if you take the variation out, you're going to take that waste out of the system as well. So now we've talked about the quality benefit, the cost reduction benefit, and we also talk about the revenue enhancement. There are also ways to decrease variation and increase revenue. That's improving clinical documentation, it's improving throughput and backfill with patients, just improving the productivity overall in the hospital, and also reducing insurance denials as well as another example of revenue enhancement. So there's three primary benefits of clinical variation: expense reduction, quality improvement, and revenue enhancement.
Okay, great, Laurie. Well, now that we know what clinical variation is and how the first steps include baseline analysis, what's next? How do you activate a clinical variation reduction study?
So with any clinical variation program or project, it begins with a performance improvement process. And any performance improvement process framework that a hospital is using, PDSA or DMAIC methodology or any type of PI process can be leveraged to implement a clinical variation program. The clinical intelligence has designed its own framework, and that embeds multiple PI frameworks into our approach. It begins with defining the vision and the philosophy of your hospital. So many times clinical intelligence is called in to help with clinical variation projects, but we have to really make sure that the senior leadership has the definition and we have defined the vision and the philosophy for the hospital. And I mean philosophy because it's exciting to think about the cost reduction, but not at the expense of quality. So we really have to talk about take the variation out first, improve the quality, then cost, not cost-cutting medicine because that could compromise care. Then we get into the governance. Who's going to lead the program? Does it come from the P&T committee? Will it be supported by the utilization management committee or the medical staff, special teams? Or sometimes hospitals have performance excellence councils and patient safety councils. So really, it doesn't matter where the program lives as long as it's supported by the medical staff, and we call them medical staff champions because we always believe that you can't really activate and deploy evidence-based medicine unless you have physicians leading the way. You just can't. Physicians can review the evidence, they can incorporate these evidence-based practices into their order sets, and then we can get these approved by the medical staff. It also takes a lot of teaming. So all the disciplines, nursing, laboratory, pharmacy, imaging, dietary, lot of team members come together, and we call them clinical consensus teams. So you now have the structure in place, you have your data, you have to have good analytics. You can't really get very far with clinical variation if you don't have a platform to which you can drill in and create that insight. Clinical Intelligence has developed a platform called ClinView, where we can bring that data in, and within 30 days we can build that platform for an organization, and that really helps with time to value. So those are the key steps in activating a program, and it really is a very collaborative approach. It typically takes an organization to get ready for the program about 30 days or less, to just make sure that everything is in order. The resources, the analytics platform, the right cost accounting methodology. We have to really understand what cost accounting confidence the leaders have. Sometimes the leaders have an RCC, or ratio of cost to charge methodology, but that's not going to be as confident in drilling into the activity codes if the hospitals are using an allocation method versus a more of a activity-based accounting system. So clinical intelligence also helps with analyzing the current state of the costing and activating the right level of cost accounting methodologies for hospitals. So readiness is a big, important key competency for a clinical variation program.
All right, that's excellent, Laurie. And with all that you've shared with us today around clinical variation reduction, my final question is about sustainability. How do you ensure a sustainability of the performance improvement process?
Sustainability is such a key word. It's really the ability to ensure that this process and these outcomes are maintained for long term at a certain rate or level. And this can be done in a lot of ways, but the most important is to measure, to continuously monitor and measure the key performance indicators, and to remember to feed back that data to your key stakeholders. Where hospitals fail often is they get excited about starting a clinical variation project, but they fail to communicate back to the clinical consensus teams on a routine basis. They may do it a couple months, and then another project comes along and it just kind of fails. So what we do is we hardwire the dashboards and scorecards and automate those, so physicians and leaders can receive those reports in their inbox, and they can monitor their key performance. So that's one way. Another way is through what we call data discovery conferences. Once a month, we come together, we review the reports and the work plans, and we might modify those work plans if we're not getting the results that we set out to achieve. And it's really about targeting education. We're never going to get a perfect improvement pattern, but we can make really significant strides to improving performance with the right data monitoring, the right touch points, and the right education.
Okay, Laurie, that was great. Very informative. We want to thank you for the time today and sharing CI's programmatic approach to reducing clinical variation and improving margins. If you would like to learn more about clinical variation reduction or other proven strategies for clinical, operational, and margin performance improvements, please contact Clinical Intelligence with the contact information listed on the screen now. My name is Adam Klingsheim. Thank you for joining us, and we'll see you on the next one.